Hello, my name is Jose Rodriguez Castro. I'm a resident physician at Aventura Hospital. Now I'm presenting my case report titled Asymptomatic Large Loculated Pneumothorax Secondary to Pulmonary Septic Emboli, a case report. Loculated pneumothoraces often arise from the formation of adhesions between the visceral and parietal layers in the setting of pleural disease. We are presenting a case of a small loculated pneumothorax progressing to an asymptomatic large multi-loculated pneumothorax in the context of multiple pulmonary septic emboli. Our patient is a 42-year-old male with a history of IV polysubstance use disorder, tricuspid valve endocarditis, complicated pneumonic effusion, and multiple pulmonary septic emboli, who presented to our hospital with concerns of abnormal radiographic findings on a follow-up CT of the chest. The patient had been recently hospitalized at another institution for diabetic ketoacidosis and MRSA osteomyelitis. At that time, his hospitalization was complicated by pulmonary embolism requiring mechanical intubation. CT chest that was done during that admission revealed multiple capillary lesions and a small right loculated pneumothorax. Due to the stability of the radiographic findings and his clinical status, this was managed conservatively. This patient was treated with 4 weeks of vancomycin and was eventually discharged to an LTAC. Upon admission to our facility, his vital signs were within normal limits. He denied any respiratory symptoms as well as fever, chills, or chest pain. CT of the chest was significant for a large right loculated pneumothorax with pleural adhesions, compression of all three lobes without mediastinal shift, and multiple stable peripheral cavitary lesions and subpleural nodules, concerning for septic emboli. A CT-guided right chest pigtail catheter was successfully placed, and post-procedure chest X-ray showed significant improvement of the right lung aeration. A pneumothorax typically can be loculated in the presence of pulmonary adhesions. These pulmonary adhesions may form as a sequela of pleural inflammation from prior pneumonic effusions, empyema, pleural tuberculosis, or incomplete pleurodesis. Multiple authors have described pneumothoraces arising from septic and pulmonary emboli due to right side endocarditis. However, all of these described patients were symptomatic. Our case, to the best of our knowledge, represents the first asymptomatic large loculated pneumothorax due to septic pulmonary emboli. We theorized that our patient initially developed a small right pneumothorax secondary to rupture of a subpleural capillary lesion into the pleural space due to barotrauma during mechanical ventilation. This slowly progressed to a large multi-loculated pneumothorax causing compression of all three lobes. His previous history of a complicated pneumonic effusion likely caused the development of pleural adhesions. These adherences prevented the abrupt and total collapse of the right lung, leading to the loculated appearance of the pneumothorax and its asymptomatic presentation. Although this patient's initial pneumothorax was the result of a septic pulmonary emboli, its slow progression in size, loculated appearance, and asymptomatic display are unusual in their presentation. It is important to know that close follow-up should be encouraged in patients with pneumothoraces with non-pleural disease, as early diagnosis and treatment are essential for improving outcomes. Thank you.